It's a pleasure to introduce our distinguished speaker, Dr. Noor Al Khori. Dr. Noor Al Khori graduated from Weill Cornell Medical College in Qatar in 2010. She completed her residency in radiology at York-Presbyterian Hospital, Weill Cornell Medicine in New York City, followed by fellowship in breast imaging also at NYPH. She then pursued a pediatric radiology fellowship at Stanford Children's Hospital in Stanford, California. She currently works as a radiologist specialized in women's and children's imaging at Sidra Medicine in Qatar. Dr. Al Khori has a Master of Science in Health Economics and Policy from London School of Economics and a Master of Arts in Public Policy from the University of Chicago. Her interests include quality and safety and being an advocate for the health of women and children. Today, Dr. Khori will talk to us about economic considerations in designing a national breast cancer screening program. Thank you, Noor, and welcome.
Hi, everyone. Wherever you are and whatever time it is, anywhere in the world, I'd like to, first of all, introduce myself. My name is Dr. Noor. Today, I'll be talking to you about economic considerations in planning a national breast cancer screening strategy. I have a background somewhat in health economics, and this is an area of interest to me. So hence, this is why I'm giving you this talk. So moving on to the objectives, basically we'll be going over just in general some history, how did screening begin, going over, touching upon basically the difference between organized or centralized national healthcare screening programs and contrasting them with opportunistic screening, which is what happens mainly in the USA. I'll be touching on the basics of cost effectiveness analysis, since this will be the primarily the economic analysis portion. And I'll also be introducing you to some simulation models that are useful in cost effectiveness analysis, which is a key factor in determining a national breast cancer screening strategy. We'll also be going over, some best practices for how to perform a CAA, a good CAA. And we'll also be discussing some limitations and challenges. So moving on, over the past few decades, we know that many countries have started to do national breast cancer screening, and this is the case in Europe, Canada, Australia, Japan, and in some Middle Eastern countries. So as we mentioned, this is when you have a very national centralized screening program that's set up by the Ministry of Public Health or the government, and it allows usually free access to breast cancer screening in many parts of the world. This is different than in the US, where of course it is in the US, it's primarily a private healthcare sector market. So it's very different there in the US. So instead of women actually getting invited to participate in the national healthcare screening program, usually the woman will have to get a referral to a breast imaging center from her primary care physician. And there are many different breast cancer screening centers in the US. They're all sort of scattered. They're not part of a nationwide screening, centralized screening program. We know that the benefits of screening were really shown through very early randomized clinical trials. If you notice there, I've listed that one very good meta-analysis of very high quality randomized clinical trials actually showed that there is a 20% reduction of breast cancer mortality with screening. And hence, this is why many countries want to have nationwide screening programs. However, we do know that many countries follow different guidelines when it comes to the age range, as well as the screening interval or how often to screen. And actually, even within the same countries, for example, the US, different institutions may have different guidelines. So why is that? And how does cost effectiveness factor in? So cost effectiveness is one reason why we have different guidelines. It is a key factor in determining a country's screening strategy. I would just caution that it should not be the only factor, because you also want to consider things like access and quality of the program itself, but it is a major element that is taken into consideration. So, and we know that when you evaluate a breast screening program, you often follow certain short-term indicators or KPIs. And this is, for example, things like participation rate, breast cancer detection rate, tumor stage, false positive, false negative, sensitivity, specificity, et cetera. However, when it comes to assessing long-term impact, it's challenging. And usually when we talk about long-term impact, we're primarily talking about mortality reduction, or MR, as it is abbreviated here. So we know that mortality reduction is influenced by the degree of participation in screening, and it often takes many, many years for us to reach a certain desired coverage of the target population. And also randomized clinical trials, although they are a gold standard for assessing effectiveness of interventions in medicine in general, they may not be ideal for assessing effectiveness of screening programs. We know that clinical trials are expensive, time-consuming, they require extremely long-term follow-up, and there are also some ethical concerns. So we can't really just do randomized clinical trials, because when you have a control group, you would theoretically be depriving the women in that group from theoretical benefits of screening. So there are some ethical concerns with actually performing randomized clinical trials. So this is where simulation models come in. So simulation models allow you to predict mortality reduction from screening. They simulate sort of a randomized clinical trial. And you can also even, see where the mortality reduction occurred from screening, as well as where it occurred as a result of adjuvant therapy, which is another added plus. Simulation models can actually extrapolate data from many resources, including randomized clinical trials, and be used to predict the benefits and the harms, as well as the costs of a particular screening strategy. So, countries a lot of times rely on these simulation models. They can also be used to compare the costs and effects of alternative screening strategies, which is another useful plus, because we can actually see, what are the different advantages and disadvantages of different strategies. Now, economic analysis in healthcare primarily boils down to cost effectiveness analysis. So this is very, I'm just going to try to simplify it here. It all really comes down to calculating your costs. And these can be costs of organizing and implementing a screening program, and then comparing them to effects. Now, when we talk about effects, usually we look at absolute life years gained, but we also have to actually adjust for quality of life. And effects can be positive, so life years gained, and they can also be negative. So we know that, for example, screening has many negative effects, such as pain, anxiety, overdiagnosis, unnecessary biopsies, and also morbidity of surgery and radiation later when the woman does actually have breast cancer. So we have to basically factor in all these different effects and their probabilities, as well as adjust all effects for quality of life. And the way we adjust for quality of life is we use utility values. Utility is basically usually a number between 0 to 1. 0 is considered to be death, 1 is perfect health, and utility values are a range of numbers in between, which basically show you, how much quality of life you have compared to 1 and 0. We know that cost effectiveness analysis are very limited. We cannot generalize the results from different countries because all different countries use different input data, they use different methodologies in doing the CA analysis. Although I showed you a simplified calculation, there are actually much more calculations to do, and you can choose which one or which calculation to do. We also have different models. So we talked about simulation models. Well, there's a bunch of them, and actually all of them have different assumptions and different input variables. And finally, we know that although there is an abundance of literature from the OECD countries, there's a huge paucity of information for the MENA region. And in terms of simulation models, so I mentioned there's many. I've listed some here. So they all use different types of modeling. There's a Markovian modeling, discrete event simulation, etc. They all have some advantages and disadvantages. Overall, though, the take-home message is all models will overestimate mortality reduction compared to the mortality reduction estimated by randomized clinical trials. And usually there may be differences in the cost effectiveness ratio, but all of the ratios actually turn out to be cost effective, given that we're using the definition of WHO, which is, who has a certain cost effectiveness measure, and it's 1.3 times the GDP of a country. So just going over some best practices that maybe we should keep in mind when we're trying to undertake a cost effectiveness analysis in order to plan a national screening strategy. We really need to have strong epidemiological data. So this is very important because we need to calibrate input parameters when we actually put in the parameters into our model. Cost data should also be available and accurate. This is not the case in many situations. We have to choose the model carefully, but recognize that all models are built on assumptions. So no one model is perfect. Ideally, the model should include data on things like breast density, the harms of screening, as well as maybe even factor in technological advances such as tomosynthesis and new treatments for breast cancer, just to make it more realistic and more accurate as a measure. We always have to sort of adapt the model to a local context. So what does that mean? We want to put in as much as possible age-specific breast cancer incidence rates within a country, test sensitivity and specificity. So in this case, mammography sensitivity and specificity within a nation, the distribution of cancers according to age, etc. Also, screening participation rate, extremely important. So many models assume that participation rate is 100. However, in most scenarios, it's actually much, much, much lower than that. In some countries, it's 20, 30%, at least in mine. Effects and costs must be discounted. So this discounting is a concept in health economics where we basically adjust for time. It's just an adjustment we have to make. And then usually we have to carry out some sort of sensitivity analysis and also validate the model. So there are many forms of validation which can happen. Now, the limitations of the models. So I've mentioned maybe before that many models were calibrated in accordance to existing Western databases because these are the databases that are available. However, we know that breast cancer may differ between Arab women and women in the West. There are differences in lead times and also natural history of tumors, and many studies have shown this to be true. Sometimes when the cancer registry data is not available, that can cause a lot of problems in carrying out the cost effectiveness analysis, or basically limiting us. And finally, utility values, there can be a wide range because people have different cultures and experiences, and also treatments are different. So that even that area is kind of a gray area. They're usually derived from surveys of a specific population, but in many cases, we haven't actually had a survey. For example, right now, there are no currently standardized set of utility values that are specific for breast cancer screening, specific to the Arab world. So those are just some limitations. Other limitations, for example, there's a lot of focus on mortality reduction, but not so much on interval cancer rates. And interval cancer is important because this is the whole point of screening. We're trying to detect early stage disease. And in many cases, detection of early stage disease is actually much more cost effective than dealing with late stage disease. There's a lot of lack of data when it comes to breast density in the Arab world. DCIS has basically a lot of debate on what proportion of DCIS progresses to invasive disease. This is another issue for our models because we'll have to make a certain assumption, and that assumption is not very accurate in many cases. High-risk lesions have not been studied as well. Cost information I mentioned, sometimes very difficult to obtain. There is currently no consensus on treatment of breast cancer, so treatments can actually vary, which is another problem. We have constantly new and evolving technology, which has to be factored in. And obviously, there is a paucity of radiation centers in the MENA region when compared to the West, so that's another issue where we are limited. So in conclusion, I've gone over, sort of how to use cost effectiveness analysis to plan a national breast cancer screening strategy, the many factors that go into the calculation, some advantages and disadvantages of simulation models, and obviously the elements of how to do it, a good CAA, and as well as the limitations that we can face. So thank you for your attention, and this is my email if you have any further questions. Thank you so much.